I'm Wendy Terrell from Platform Q Health Education, and I'm joined today by Dr. Rich Beezer from Joslin Diabetes Center and Harvard Medical School. Dr. Beezer and I were meant to present this poster at the 2020 American Diabetes Association Scientific Sessions in Chicago, but unfortunately, due to COVID-19, the scientific sessions have been changed to a virtual meeting, and we're happy to present the poster to you today in this virtual format. The poster itself highlights results of an educational evaluation of a CME initiative. The program was a three-part educational series, wherein each session built upon information from the prior, and it demonstrates a successful curricular approach to education. Also, as we move forward towards more of an online existence, the live, online, and on-demand formats are methods of educational delivery that will likely become more common to our day-to-day. So the focus of the CME program itself was to address identified gaps in primary care providers' ability to treat type 2 diabetes with insulin. Importantly, I'd like to acknowledge the grant supporters of this program for their generous support: Lilly, Novo Nordisk, Medtronic, and Mankind Corporation. Here, you see our disclosure slide.
But both glargine and detamere were smoother and had more of a prolonged, consistently prolonged effect over the 24 hours than NPH did.
What about the prandial insulins?
So with prandial insulins, obviously we want to closely mimic what the body would usually do in response to a meal.
How do we switch to these insulins?
Well, here's some interesting, a slide that really summarizes that. If you are on a standard analog and you switch to U300 glargine, you may need a slightly higher dose, which was demonstrated in that study comparing U100 versus U300 glargine.
I like to liken this process from the physician side as a stepwise perspective on insulin treatment. Shown in this slide, there are a lot of things that are involved in overseeing the insulin treatment. Well, our learners seem to have aligned with that, because the most popular answer was C, reduce the dose of basal insulin. Correct. And then the second most popular, and again, it was all that apply, was to add rapid insulin before supper time. As you saw from these excerpts, this educational program consisted of a series of 3 one-hour CME sessions that were launched live online in June of 2019 and remained on demand for 6 months. The design was that of a sequential curriculum. We started with Program 1 presenting knowledge-based learnings on an update of insulin options for diabetes. Then Session 2 discussed how to design insulin replacement therapies for type 2 diabetes, prompting learners to improve their skills. Session 3 was a workshop, allowing learners to participate in the design of insulin replacement programs through ARS questions about patient assessment and treatment options and faculty discussion. The learning objectives are listed here and are reflected in the curriculum just described. They cover knowledge about new and evolving insulins, the indications for the use of insulin for people with type 2 diabetes, and its use in various combinations, methods to initiate and advance it, and the indications for use of devices. Our faculty included myself, Dr. Martin Abramson of Harvard Medical School, and Dr. Alyssa Siegel, a PharmD and a CDE from Joslin and the MCPHS University. Joslin was the accredited provider.
Here we have the approach to educational evaluation that we used to measure the impact of the program on knowledge, competence, and behavioral changes among learners. So it was a survey-based approach. We had an immediate pre-test and an immediate post-test. And then after a 2-month waiting period, we administered a 2-month follow-up post-test as well. And it was during this follow-up post-test that we were able to ask questions that were more behavioral in nature, since learners would have had the opportunity to see patients in practice. And here we see some engagement statistics So there were 2,230 total learners, and those are unique learners. There were 604 slide downloads, over 1,000 CME credits were issued, and 1,176 responses to in-session polling were received.
The results showed a significant positive impact among learners, with 76% reporting that the activity positively impacted patient experiences and outcomes. Some of the free text comments gleaned from the many evaluation comments are listed on this slide. Reduced A1C results and better glycemic control. Patients became more confident about having therapy, overcoming insulin or clinical inertia, better compliance due to less fluctuation of blood glucose. Patients have returned with their blood glucose logs, reflecting improved fasting glucose without lows during the night. Patients feel heard and are happy discussing their treatment options. We also demonstrated positive impact on clinical practice, where 76% of learners reported that this activity had a positive impact. Among the write-in samples, representative comments are listed here. I'm more aggressive with offering insulin, less referrals to specialists, started insulin earlier, it helped to be able to adapt the latest guidelines, improved my use of insulin, including titration for my patients, and enabled me to pick therapy that fits the patient and his or her life. These are all very important responses in terms of impacting behavior in the clinical setting.
And here we have results of the pre and post testing that was administered at 3 points in time during that evaluation. So during the pre-test, the immediate post-test, and then at the 2-month follow-up point, there were 8 competence or knowledge questions that were asked to learners. And all 8 of these questions did show statistically significant improvements pre to post. And there was a large effect size, a Cohen's d of 1.13 for that pre to post period. On the right side of the slide, learners reported various areas where they saw the greatest impact 2 months following the education, and the most reported impact for each session is shown here on the poster. So for session 1, I am more confident in managing all insulin formulations in my patients with type 2 diabetes. The greatest impact for session 2 was a greater ability to identify which patients were appropriate for intensification with injectable therapy. And for session 3, similar to session 1, improved confidence was reported in managing a variety of insulin formulations.
There are a number of key take-home messages from this program. First of all, we did get positive feedback on the success of this program in terms of outcomes, questions, and the free text comments from learners. This slide lists some of the key topics noted by learners as potential further educational topics. However, beyond that, the impact of the subsequent COVID quarantine highlighted the importance of evolving educational methodology into approaches appropriate for distance learning. It cast the approach taken by this program in a new light. The program was designed as a serially based live online learning event. It progressed through a knowledge-based initial program leading to skill-building instruction and then case-simulated training. This sequential format has proved to be effective in improving clinical knowledge and skills. As we evolve increasingly into virtual education, this approach and the learnings we've gotten from developing and assessing it will drive the design and implementation of further educational endeavors. On behalf of Wendy and I would like to thank Lilly, Novo Nordisk Incorporated, Medtronic, and Mankind Corporation for their support of this program, and acknowledge our colleagues at Joslin Diabetes Center and Platform Q Health Education for their contributions to this project. Thank you very much for listening.